Warm welcome to everyone, every survivor. Congratulations for your success in this strange situation. Hopefully soon we shall meet each other face to face, but now it's this movie again. Perhaps the only advantage of that I will have time to finish in all the lecture. This semester is about splanknology. Hopefully the word is not new for you, because in embryology you came across with splanchno plural. Splanchnos means internal organ. The same in Latin is viscerum, viscera. So viscerology and splanknology means the same. So internal organs is the main topic in this semester. There are many apparatuses, different apparatuses you've heard about previously. Amongst them is respiratory, digestive apparatus, and so on. We should start with the GI tract, the digestive system, digestive apparatus. Here's a very nice mechanistical illustration of all the happenings within the body. It's too small to see, but like a machinery, everything is imagined inside the body. With the digestive system we start, so therefore good to begin at the beginning, which is the inlet of the digestive system. This is the oral cavity. Behind of it, the pharynx is the next component. So these are the topics for today. This is not human oral cavity, but quite a funny oral cavity, as well as many variations developed during phylogenesis according to the specialized goals, what the oral cavity should correspond to or should be good for. Amongst them, very different things you can see, including this huge and smelly thing. And now we are approaching to the humans. This is almost human. This one is completely human, but quite resembling to each other, as well as many different things the oral cavity you can do with. Just to determine the oral cavity, good to tell the beginning and the end, so from where till where it lasts. And the inlet of it is the oral opening, or rima oris, between the lips. That's what everyone is familiar with. And posteriorly it lasts still a window, an opening, which leads into the pharynx, this muscular tube behind nasal oral cavity and the larynx. So from here till here it lasts. Two different parts we should distinguish. One is not in front, but outside the upper and lower rows of teeth, between the teeth and the lips, and that is called the vestibule of the oral cavity, the oral vestibule. This one is horseshoe-like according to the arches of the teeth, the dental arches. And in case of closed teeth, there is almost no communication between this part of the oral cavity with the rest of the oral cavity, except behind the last tooth. Just a very thin slit makes the communication. But opening wide the oral cavity, the two horseshoes fit into each other, and finally you can see all the vestibule as an oval space outside the teeth. The rest of the oral cavity is the proper oral cavity proper. And this oral cavity should have, of course, walls. The oral opening is found on the anterior wall of the oral cavity. Very familiar, beautiful picture you can see here. The upper and lower lips, which are covered by a very thin skin, so the keratinization of the stratified squamous keratinizing epithelium is much less at this region, as well as many capillaries this part contains, and that makes it red. And that is a name it gives a name. Lip red or rubor labii is the name. The upper and lower lips join each other at the angle of the mouth with fused muscles inside, and these fusion of muscles makes small tubercles on both sides. These fusions are called the labial commissures, left and right labial commissures. On the upper lip, in the midline, there is a small elevation, the tubercle of the upper lip, and that is to hold the nipple of mother during childhood, during the postnatal life in position. Above this, there is a shallow vertical groove which extends up to the base of the nose, and that is called the philtrum. This is a specific part of the upper lip because, as you are going to hear soon, has got different source of origin than the rest of the upper lip. The upper lip is separated from the rest of the face by oblique grooves, and these are the nasolabial sulci, as well as the lower lip is separated from the chin by a horizontal groove called the mentolabial sulcus. So the walls are the anterior, superior, posterior. Posterior has no inferior and lateral walls. The anterior and lateral walls in structure fairly well correspond to each other because both of them consists of mostly skeletal muscle inside, but the muscle is covered on the outer surface by skin of the face, and inside the muscle, the mucous membrane of the oral cavity. So that is a general structure. The most important muscle in the anterior wall is the orbicularis oris muscle. This muscle belongs to muscles of facial expression. Most of these muscles are to be studied in the third semester, but that muscle, as well as the next one belonging to this group, are well to be known for the coming exam as well. Orbicularis oris muscle, circular as the name says, and several other muscles project into this muscle, making the lips very movable, necessary for speech, for example, or many other functions. These are levators, depressors of the lips. The wall, lateral wall of the oral cavity is formed by the buccinator muscle, trumpet muscle, buccinator muscle, plus it is strengthened by a huge accumulation of fat. This is a buccal fat pad of Bichat. This muscle also belongs to the muscles of facial expression, and it has a very interesting origin. Not from bone, by a tendon or fleshy border it originates, but it has a common origin with another muscle. This other muscle posteriorly comes from this common. This is a very thin tendinous line, like a stitching, and this tendinous line is called raphe. Today, this is new for you, but many raphes we should come across with. So anterior, the muscle fibers of buccinator originate from this raphe. The raphe is stretched in between two bony points. Between the, as the name says, suggests to you, the pterygomandibular, therefore from pterygoid process, from the medial plate of the lower part of the medial plate of pterygoid process, it comes from, and jumps to the mandible, to the lingula of the mandible. From here the muscle fibers anteriorly come, and those coming from above mostly blend with the muscles of the lower lip, and those coming from below mostly with the muscles of the upper lip. Muscles of facial expression, only thing what you should know about many times you should hear, that all these muscles are innervated by the seventh cranial nerve, by the facial nerve, indicating the origin of them, embryonic origin of them. The roof, mostly known by you, at least the anterior bigger portion, which is bony, according to that we call it hard palate. You remember, you should revise the skull, you remember the bony components, the palatine plates of the maxilla and the horizontal plates of the palatine bone fused in a cross-line suture system, doesn't matter. And now you should just cover it on its lower surface, the hard palate, and you end up with the normal roof of the oral cavity. Attached to the posterior margin of the hard palate, there is a thing which is completely new, going to be new for you, and that is a soft palate mainly containing muscles inside. We should discuss them in detail soon. In the midline, there is a raphe in the soft palate. There is a second raphe today, common origin of muscles in the midline. From the posterior end of it, a small flashy process hangs down, and that is called the uvula. On the hard palate, when you've learned the incisive foramen in the previous semester, a small accumulation of mucous membrane makes a papilla. This incisive foramen lets the blood vessels and nerves supplying mostly the hard palate to come in, or anterior part of the hard palate at least, to come into the oral cavity. And transversely oriented ridges are found. These are called the transverse palatine folds. And these folds are extremely unique for each of the individuals, so equally good for identifying persons as the fingerprints are. As well as these serve for production of different sounds when the tip of the tongue is needed. T, and such sounds are produced here. Muscles so that is a posterior view from the naked soft palate. Naked means that the mucous membrane has been peeled off or removed, and this shows the muscles which insert into partly the midline raphe I have mentioned before, or partly in a horizontal tendinous plate. You remember the flat tendon is called aponeurosis. According to that, you should call this palatine aponeurosis. So either muscles insert into it or muscles originate from it. These muscles, the muscles coming from above, this is back view, don't forget, and therefore this muscle lies more to the back, so the obliquely oriented and posteriorly located muscle, according to the orientation of the fibers, can lift the soft palate. So according to that, levator veli palatini is the name of it. And there is another muscle in front of it, so more anteriorly, more to the vertical position, and this is called tensor veli palatini. Question how a vertically oriented muscle can tense something which is horizontally located. It's very easy. You remember the pterygoid hamulus you've learned on the lower edge of the medial plate of pterygoid process, and on this hamulus the tendon of the tensor veli palatini bends by almost 90 degrees, and therefore the pulling direction from vertical is transformed into horizontal, and therefore effectively can stretch all the soft palate. Muscles originating from this palatine aponeurosis. There are two pairs of muscles oriented down according to an arch-like manner. One goes to be inserted into the tongue and the other to the pharynx. According to that, palatoglossus, palatopharyngeus is the name. Easy to figure out which one is which one, because everyone knows that the tongue, being in the oral cavity, is in front of the pharynx, so the anterior must be the palatoglossus, and the posterior, blending with muscles of the pharynx, should be the palatopharyngeus muscle. One pair of very small muscles are oriented vertically within the uvula. The uvula mostly not responsible for movement, so this muscle has not much importance. One importance is that the problem with the nerve innervating could be diagnosed, because the working muscle pulls the uvula to the normal, so pulls away from the wrong direction. How these muscles can work? Of course, the most important function of them is to execute the swallowing. The first first happening of the swallowing is lifting and stretching the soft palate using the levator and tensor veli palatini muscles. That is needed for the second step, because lifting the root requires a fixed origin of the muscle being responsible for that. So tensing the soft palate allows the muscus palatoglossus to pull up and pull backward the root of the tongue, by this pressing the bolus into the middle level of the pharynx. And after that, the pharynx should be lifted by muscles to be discussed a little bit later, lifted up to the bolus, and from here consecutive constriction, it means peristaltic movement, presses the bolus down to the esophagus. Here you can see dissected material showing the two muscles. One can realize the two choanae separated by the septum of the nasal cavity, the nasal septum. And next to the choanae, there is one muscle more oblique and being posterior. This is back view, and this is the back view what you can come across with on the exam. So the one which is more oblique and lying to the back is the levator, and more anteriorly, vertically oriented, is the tensor viri palatini muscle. The floor of the oral cavity is again muscular, but there are other muscles contributing to it. The proper floor, which is called the oral diaphragm, is formed by the two mylohyoid muscles. These mylohyoid muscles originate from the mylohyoid line, well known by you, knowing the mandible, from the mandible mylohyoid line, and those lying closer to the midline unite with each other in a midline raphe. And this one is called, that is the third raphe today. This one is the mylohyoid raphe. The most lateral fibers of the mylohyoid muscle reach the hyoid muscle, hyoid bone, giving name to the muscle. So that's why we call it mylohyoid muscle. So this is the oral diaphragm. There are additional muscles strengthening this diaphragm, partly above, partly below. The one lying above, next to the midline of this paired muscle, is geniohyoid muscle from the internal aspect of the mandible. It originates and reaches the body of the hyoid bone. Sorry, I didn't tell you that hyoid bone is the newly to be studied bone, but not much parts. It has a horseshoe-like body, corpus, as well as this one is a lesser horn projecting upward and a greater horn projecting backward. So this geniohyoid reaches the body of the hyoid bone. Very good to keep in mind that everything above the mylohyoid line, according to that above the mylohyoid muscle, should lie within the oral cavity, and everything below should be a component on the neck. So this last applies to these two muscles, anterior bellies of digastric muscle. Also, you've learned the digastric impression next to the midline, below the mylohyoid line on the mandible. And this one only strengthens the floor of the oral cavity from below. In cross-section, very schematic illustration, but in one aspect, it's good illustration, shows the same muscles, the floor of oral cavity, mylohyoid, two mylohyoid muscles, but there is no raphe indicated on this drawing. Above it, the geniohyoid muscles, below this, the anterior bellies of digastric. And once more, I should emphasize that everything above the mylohyoid line is component of the oral cavity. Buccinator muscle forming muscular part of the cheek as well, the lateral wall as well, well seen. And here you can recognize the huge paranasal sinus filling almost completely the body of the maxilla. That is the ISTHMUS sinus, or the maxillary sinus. And the drawing shows you a very intimate relation between the upper posterior, the roots of the upper posterior teeth, these are the molars, which are in some of the cases not even separated from the maxillary sinus by bony plate. Sometimes it's a very thin bony plate, but only mucous membrane makes the separation. According to that, easy to imagine that in both directions, inflammation can spread either from the sinus onto the tooth, but most frequently the inflamed tooth will make sinusitis on one side or the other side. The posterior opening of the oral cavity, I think, very familiar to everyone looking into mirror checking the palatine tonsils sometimes. So a unique shape it has got. From above it is bordered by the posterior margin of the soft palate from where the ovula hangs down. But this soft palate continues on both sides into double arch. Anterior arch is produced by the muscle descending to the tongue. So this muscle was the palatoglossus muscle, covered by mucous membrane, making an arch. This one is called the palatoglossal arch, the same name as the muscle inside has got. The posterior contains the muscle going down to the pharynx, palatopharyngeal muscle, and therefore the arch produced by the muscle should be called palatopharyngeal arch. In between them there is a depression, and this depression accommodates the most important, most vulnerable tonsil of ours. Soon you are going to come across with definition of tonsil, not yet, but soon in histology. So once it's good to tell you, aggregation of lymphatic follicles covered by mucous membrane equal to tonsil. So this tonsil has got many lymphatic follicles and covered by the oral mucous membrane of oral cavity, and this is according to the position called the palatine tonsil. Therefore, the depression should be called tonsillar fossa. The floor of the oropharyngeal isthmus is formed by the root of the tongue. Talking about characteristics of the tongue has got a unique shape, so rather you should tell that something resembles to a tongue than the opposite. So it has got an apex anteriorly, freely ending, and an anchored posterior part, which is the root of the tongue. In between them is the body. The dorsum of the tongue continues into the mucous membrane covering the lower surface according to the margin of the tongue. There is one V-shaped line separating the body from the root, and this is called sulcus terminalis. The name terminal tells you that something begins here and something ends here, and this sulcus terminalis is the borderline between two parts of the tongue developing from different germ layers. And everything anterior to the sulcus terminalis has got ectodermal, and everything behind has got endodermal origin. A single row of biggest lingual follicles, don't mix it with the lymphatic follicles here. So the biggest lingual follicles, these circumvallate papillae, are aligned with the terminal sulcus. These are very easily characterized. Anterior part, according to the appearance, is called papillary. So these papillae of the tongue are located here. Not only these big ones, but the very small filiform, fungiform papillae make it a very smooth but irregular, a little bit irregular surface. Posterior part has got bigger elevations representing lymphatic follicles beneath the mucous membrane. So according to that, many lymphatic follicles covered by mucous membrane equal to a tonsil. So the name of this part is the follicular part. Don't forget just the dorsum of the tongue, the back of the tongue we are talking about. And this follicular part equals to another tonsil, and this is called the lingual tonsil. Behind the root of the tongue, so somewhere at the border between oral cavity and the posteriorly lying pharynx, are two depressions, and these depressions are frequently asked on the exam, since late Professor Flerko has got one evening a very good fish soup, and one fish bone was stuck into the mucous membrane here, and extremely rapid edema it produced, because the loose connective tissue deep to the mucous membrane is responding to edema, to mechanical insult, and almost making the swallowing of Professor Flerko, and therefore you can expect this question to be asked. These are called the epiglottic vacuoles. This is a new term. So epiglottis is nothing but the cartilage making the roof or partly covering the larynx itself. So according to that, the name is logical. Glossoepiglottic folds are the ones which separate epiglottic follicles, and the folds are three in number: one in the midline, a median, and two lateral glossoepiglottic folds are found here. Muscles of the tongue. Everyone knows that the tongue is full of skeletal muscles, and scattered in between the fibers are beautiful small salivary glandules. So the muscles are to be discussed. Two groups we should distinguish. One comes from other source than the tongue, therefore extrinsic muscles are these, making the tongue extremely movable. One of them has been discussed previously, this palatoglossus, coming from the soft palate, not illustrated on this lateral view. Up next is very nicely seen coming down and anteriorly from the styloid process, originating on the medial side of the styloid process. That is according to this called styloglossus muscle. I think easy to figure out the function, because knowing the origin and insertion, you can just imagine what the contraction of the muscle can do. So this one can lift the root of the tongue as well as pull it back. The next muscle is the one which originates from the hyoid bone body and the greater horn of the hyoid bone, and not clearly vertically ascends, but a little bit anteriorly oriented. According to that, if it contracts, then it can pulls down and retracts the tongue. This is called a hyoglossus muscle because of origin and insertion of it. All these muscles are paired muscles, of course. The next one originates from the inner aspect of the mandible, just above the muscle we mentioned before. These are the geniohyoid muscles. And the same origin, a little bit higher it has got, but inserts to the tongue. Therefore, the name is genioglossus muscle. According to the orientation, it can pull down, lower the tongue, as well as pull in front of the tongue. So mostly for this movement, it is needed. Intrinsic muscles, this is not the best illustration, but the best I could find. But you are going to see the histological slide of the tongue soon. In cross-section of the tongue, muscle fibers either appear cross-section or longitudinally cut, and the ones which appear in cross-section, fiber bundles, of course, should be oriented from anterior to back, and therefore these are called longitudinal muscles of the tongue. But these longitudinal cross-section longitudinal muscles are also found near to the base of the tongue as well. According to that, superior and inferior longitudinal muscles you should distinguish. The superior, I think, easy to figure out. If it contracts, then it can make the tongue concave upward, so makes an anterior posterior groove on the tongue. This is needed for reaching something stuck to the palate, for example, if you do that. The opposite function the inferior longitudinal has got, this makes convex the tongue upward, so lowers down the apex of the tongue. If it needed to find something stuck in between the lower lip and the lower teeth. And this is the movement showed on this illustration, together with the geniohyoid, which genioglossus muscle, which pulls anteriorly the tongue. Then the inferior longitudinal makes this convexity upward. The other two muscles of the tongue, intrinsic muscles, are longitudinally cut in a transverse cut of the tongue. One group of them vertically oriented, and therefore the name is very logical, vertical muscle. And by contracting the fibers, they make the tongue flat and wider laterally. The other longitudinal cut fibers are oriented from left to right, so of course transverse muscle is the name, transverse of the tongue is the name, and by contracting this makes the tongue narrower and higher, taller, thicker as well. So combination of all these muscle functions, very movable, by combination movable the tongue becomes. One thing is to be emphasized now. You must have the courage to tell on the exam that all the muscles, okay, even if it is asked which extrinsic or intrinsic, you should tell all the muscles of the tongue are innervated by the hypoglossal nerve, by the Tóth cranial nerve, since they develop from the occipital myotomes, and they gradually migrate to the final location, and therefore pulling the hypoglossal nerve. Soon you are going to see this how the hypoglossal goes, so pulling the nerve together with. Innervation of the tongue. Tongue must need sensory, taste sensory, so general sensory, taste sensory, motor innervation plus autonomic innervation, which implies both sympathetic and parasympathetic. Now only the parasympathetic is to be discussed, because the sympathetic is topic of the third semester, as well as there is a rule for reaching organ by sympathetic fibers. Always they surround arteries, supplying an organ, and they form plexuses around arteries. If you know the innervation of an organ, you know how the sympathetic fibers come to innervate that organ. So anterior and posterior part has got different nerves responsible for innervation. For general sensory innervation, this means superficial touch, temperature, and such stuffs. The lingual nerve is responsible, which is branch of the mandibular nerve. This one nicely illustrates that contributing to the formation of the tongue, the first pharyngeal arch. This is new for you, but very soon you are going to discuss in detail the derivatives of pharyngeal arches and what are these pharyngeal arches in embryology. So you should memorize now that the trigeminal nerve is the nerve of the first pharyngeal arch. For the parasympathetic innervation and the taste sensation, taste sensory innervation, the facial nerve is responsible by the branch of it, which is called the chorda tympani, and the facial nerve is the one which belongs to the second pharyngeal arch. That is about the papillary part, so the anterior 2/3 of the tongue, in front of the sulcus terminalis. The follicular part, the posterior 1/3, has got all the fibers coming from the same cranial nerve, from the glossopharyngeal nerve, and glossopharyngeal is the nerve of the third pharyngeal arch. So at least 3 pharyngeal arches contribute to the formation of the tongue during development. After this, after finishing the tongue, the teeth are to be discussed. Everyone knows the position, especially knowing the maxilla and mandible, both of them having alveolar processes. So in maxilla and mandible, according to a U-shaped line, a horseshoe-shaped line, the teeth are accommodated. Details of the teeth, we don't have time for discussion of them. Rather in the dissecting room, when you have the possibility to hold the teeth, turn it over and compare to others. So this is topic of the dissection room later. So now just the types of the teeth are to be briefly mentioned. The rows of the teeth consists of 2 halves. So altogether we end up with 4 quadrants of the teeth, and the upper half mirror symmetrical to the lower half. So the upper right quadrant has got the same arrangement of teeth as the upper left one. Next to the midline, the first teeth are very flat and having a sharp edge on it, and these are the incisives, first and second incisive. After that, very sharp-edged tooth comes. This is therefore called canine. So this is the one which the dogs have got, for example. There's a name comes from. 2 premolars follow in the row, as well as 3 molars normally in each of these quadrants. Because of the unique arrangement of the teeth, specific terms are to be known, to be learned, to describe things on the tooth, so give directional adjectives. The tubercles of the tooth, the roots of the tooth, the position of the root, position of the tubercle. So everything should be known in detail. Corresponding to the arch of the row of the teeth, everything which is closer, following the arch, closer to the mid-sagittal plane should be named mesial as a direction, mesial direction. And the opposite direction applies to when they come far apart from the midline, and that is the distal direction. You understand that why these adjectives are needed, because mesial is more or less anterior surface corresponding to the molar, and medial, almost completely medial, when you talk about the incisives. Now the same applies to directions perpendicular to mesial and distal. Everything which faces outside on the tooth, or every important part of the tooth, should be called vestibular. This is quite a logical name, because outside the row of the teeth is the oral vestibule. But this could be divided, if you want to be more precise, into labial, talking about the anterior teeth, and the labial and the posterior facing the cheek should be called buccal, but together they are called vestibular surfaces. So once more, vestibular surface in case of incisive is directed almost completely anteriorly, but the same surface in case of molar almost completely laterally oriented. Opposite surface to the vestibular, this name I don't like, but it's my personal problem. Oral is called. Everything, I think, talking about the teeth is oral, doesn't matter. Should be distinguished according to the two rows. The oral, in case of upper teeth, means facing the palate, therefore this is the palatinal surface. And talking about the lower teeth, the oral equals to the lingual surface facing the tongue. To determine one tooth, two different methods are used. One is the Zsigmondy's cross, and the other is the much more recent, up-to-date terminology. The Zsigmondy's cross is practically a cross imagined in between the two rows of the teeth and cutting into two halves. So if you want to name a tooth, then you just pick up that particular part of the cross and indicate the number of the tooth. The other uses numbers for the four different quadrants. The right upper is number 1, and then comes the left upper, number 2, number 3, number 4. And after this number, the corresponding number of the tooth is given. Talking about this tooth, for example, if you use the Zsigmondy's cross, then that is the sign, that is the indication. But considering the number of the quadrant, you use it, plus this is the third tooth of the quadrant, therefore this is tooth number 23. Or talking about this one, either with Zsigmondy's, that is the 7th in the row, but it's in the 4th quadrant, so 74 is the number of it. Everyone knows that teeth are developing first and then replaced by newly coming teeth. According to that, we should talk about deciduous teeth as well as permanent teeth. Important thing is that the deciduous, corresponding to the description before, has no premolars at all. So 2 incisive, 1 canine, 2 molars. These are deciduous molars, but no premolars are found here compared to the permanent teeth. Here you can see an X-ray of the last permanent lower teeth, and this is the 3rd molar of the lower row. And because this is the last to come, here you don't even see the eruption of the tooth, not fully developed the roots of the tooth are. So because it comes last, therefore this is also called a wisdom tooth or denscerotinus. Hard to memorize these times for me, even if I watched 3 of my children having the teeth erupted and changed. But it is to be known. The first to come are the first incisives in the lower row, and that gives a very funny and very kind expression of the faces of the babies, like reversed rabbits, so not from above but from below. The 2 teeth are erupted. After that comes the upper first incisor, then comes the second incisor in the upper row, and so and so and so. I don't want to go through all the steps. The thing is that the last to come is the second molar in the lower row, and that happens around 2.5 years of age. In general, always the upper ones, except this, always the upper ones come first, and only after the lower one follows. And then the changing of the teeth, dentition, starts at the age 6-7 years or something like that, with the first permanent molar to come behind the second molar in the upper row, and that could be a problem, because someone can think that, not counting well, that this one is still a deciduous tooth, and therefore very easily it is extracted, and therefore the permanent tooth is extracted, and it's quite a big mistake. After that comes the lower one, and so on and so on. So this is the sequence how dentition goes, and it finishes at the age of 21. So at that age, all the teeth should be replaced by permanent teeth. And here you can see an X-ray of a 40-year-old man who has got a second residual molar still embedded in the mandible, which was expected to be removed at half of the age, at around 40 years of age. After finishing the oral cavity, we should talk about the pharynx. Everyone remembers the basilar part of the occipital bone, having only one thing in the midline on the lower surface, that was the pharyngeal tubercle. So from here the pharynx, which has muscular wall, except the anterior, which is full of holes. So pharynx hangs down, and it lasts till the sixth cervical vertebra, where it continues into the esophagus, leading into the stomach. So that is the pharynx, the definition of it. And according to the different cavities with which the pharynx communicates, we should differentiate three levels of the pharynx. The highest level receives the openings of the nasal cavity, these are the choanae, and according to that, this is called nasal part of the pharynx, nasopharynx, or epipharynx. The next one, into which the oral cavity opens by the oropharyngeal isthmus, that should be called oral part, or oropharynx, or mesopharynx. And finally, from the lowest part of the pharynx, the larynx, open anteriorly, giving name to it, laryngeal part or laryngopharynx, or the hypopharynx, related to the two others. Interesting thing is to imagine how two different systems use the same tube, the cavity of the same tube. The only respiratory tract uses the uppermost level of the pharynx. Therefore, the epithelium of the mucous membrane should correspond to that of the nasal cavity. That is the pseudostratified, that is a kinociliated epithelium, stratified columnar kinociliated epithelium. Highest level of the pharynx is exclusively used by the respiratory tract. According to that, the epithelium of the mucous membrane should be the same as the epithelium in the nasal cavity. The middle portion, where the two tracts cross each other, so commonly used by respiratory and digestive apparatuses, is the mesopharynx, and the same applies to the hypopharynx. Therefore, here the epithelium should correspond to that of the oral cavity, the stratified squamous non-keratinized epithelium should be found here. If you remember the skull well, so good to remind you that repetition is needed every time, so must revise the skull again. If you remember that, easy to find out where the anteriorly the pharyngeal wall should take its origin. Where the nasal cavity ends, very good for the pharynx to start. Where the oral cavity ends, again good for the pharynx to start. Hermetically, these cavities should be separated from the general tissue spaces. Drinking a whiskey, for example, you don't want it to flow in between the muscles of the neck, for example. This origin of the pharyngeal wall should correspond mostly to the origin of the constrictor muscles of the pharynx. Two different groups we should distinguish. One could make the constriction of the pharynx, so mostly circular arrangement of fibers have got in this case. Three different levels these constrictors are arranged in, superior, middle, and inferior constrictors. But constriction of the highest level of the pharynx is not needed because it exclusively communicates with the nasal cavity. Therefore, no peristaltic constriction is needed here. So muscle is missing from the highest part of the pharyngeal wall. Here, dense collagenous connective tissue, a very strong fascia replaces the muscle, and this is called the pharyngobasilar fascia. And after that, the muscles start. Don't forget the arrangement of them. Always the lower one covers from back and from the side the higher one. So this one is an opposite arrangement to that of the tiles on the roof of the house. But it's again logical. When peristaltic movement is needed, then the highest one should constrict first, and therefore this should be the innermost one. And then the next comes, which partly covers the higher one. So superior, middle, and inferior, also illustrated in this lateral view of the pharyngeal wall. All these fibers of the constrictors unite in a single, this tendinous stitching between the muscles, again called raphe, but this is the pharyngeal raphe. The origin of the different parts of the constrictors are to be known. These names are not required, but I think if you memorize the name, or the opposite, if you memorize the name, you can figure out the origin, or if you know the origin, you can easily name the different parts. So as we said before, where the nasal cavity ends, the pharynx good to start. The lateral margin of the choana, posterior opening of the nasal cavity, was formed by the medial plate of pterygoid process, and therefore from the same line the highest part of the superior constrictor should take its origin, and therefore we call it pterygopharyngeal part. Coming down, the next part of superior has no chance for bony origin, and therefore it uses the same raphe as was used by the buccinator muscle, that was the pterygomandibular raphe, and because the buccinator uses it simultaneously, therefore buccopharyngeal part is the next. After this, there is a chance for bony origin from the mylohyoid line, where the floor of the oral cavity also originates from. From the mylohyoid line, the next part comes, and this is called myelopharyngeal part. And next is a soft origin again, coming from the muscles, from the tissues of the tongue, and therefore we call it glossopharyngeal part. The middle constrictor has got two origins. Both of them come from the different portions of the hyoid bone. The one which comes from the lesser horn, this is called chondro, and one coming from the greater horn and going backward, that is called the keratopharyngeal part. And the lowest one has origin from the cartilages of the larynx. This is completely new for you. This biggest cartilage of the larynx is the thyroid, therefore thyropharyngeal part, you should name this. And the next is the cricoid. Soon you are going to be familiar with the structure of the larynx as well. So the next is cricoid cartilage, therefore this is called the gricopharyngeal part of the inferior constrictor muscle. Just one delicatesse. This is quite an interesting thing. As you remember, the mechanism of swallowing first was stretching and lifting the soft palate up. But what if the muscles overconstruct, so the contraction is too much, then further up the soft palate would be lifted and would be reflected into the epipharynx. Not a good thing for swallowing, and therefore the first muscle fibers of the superior constrictor to contract are the ones which take origins from the palatine aponeurosis, and therefore they make a U-shaped ridge on the posterior and the lateral wall of the pharynx, to which this soft palate could be closed like a door or something like that, and after that the pressure can be increased to push the bolus backward. Now the other group of pharyngeal muscles are levator muscles. The salpingopharyngeus muscle is completely new for you. Salpinx, maybe the word salpinx is new for you. Salpinx means tube. In this case, not the uterine, but the auditory tube is to be meant. which has got opening into the epipharynx, and the medial anterior portion of the tube has got cartilaginous wall. The cartilage has got two plates, and from these plates, from the medial plate, the salpingo pharyngeus muscle descends and blends with muscles, other muscles of the pharynx. The next muscle was already discussed before, coming from the palatine aponeurosis, and it is called the palatopharyngeus muscle. And the one which lies outside the pharynx originates from the medial aspect of the styloid process, more to the back, to the styloglossus muscle, and that is the stylopharyngeus muscle. This muscle has got personal importance for you for the exam. In two aspects. One, that following it, don't forget that that was the previous level we discussed before. This is soft palate with the levator and tensor palatini muscle, that is inferior concha within the nasal cavity. So going a little bit down, there is a muscle having the same orientation that the levator has got, almost the same. And when you trace it down, you can easily find the border between the superior and middle constrictor muscles of the pharynx. This is one importance. The other thing is that this is the only place where the glossopharyngeal nerve could be found, because it descends on the backside of the stylopharyngeus muscle, embedded in the epimysium of the muscle. Special importance, some places within the pharyngeal cavity should be mentioned. In the highest level, the epipharynx, between the roof and the posterior wall of the pharynx, there is a pharyngeal fornix, or a vault of the pharynx, and the mucous membrane of it contains the third tonsil to be mentioned today. This one is the pharyngeal tonsil. Other important thing that into this level of the pharynx, the auditory tube opens. That is, a tube has got at least two openings. This one is the pharyngeal opening of the auditory tube, which from above and posteriorly is bordered by an arched elevation, and that is called the torus tubarius. And here is where the fourth tonsil is located, and that is called the tubal tonsil. The torus itself is produced by the medial, previously mentioned medial plate of the cartilage of the auditory tube. Continuation of the torus downward is a ridge called the salpingo pharyngeal fold, containing the muscle what we previously mentioned, salpingo pharyngeus muscle. And anterior to the opening of pharyngeal opening of the auditory tube, there is a less developed fold, which is salpingo-palatine fold, with no such muscle inside. This is important to emphasize, that there is no salpingo-palatine muscle at all. Behind the salpingo-pharyngeal fold, there is a vertical space called the pharyngeal recess. Not much importance it has got. The mesopharynx practically has been, the important things in the mesopharynx has been described before, because structures correspond to that of isthmus of FAUCES. The hypopharynx has got the inlet of the larynx, laryngeal inlet. You are going to come across with it very soon in lecture. And the rest of the space, which is not occupied by the inlet, is the called piriform recess, and that is the space where the bolus is pressed down to the esophagus. Two important spaces are to be mentioned, but not very much in detail. In this semester, you will be only asked about the content of these spaces, and the name of these spaces, not the exact content and not the exact borders. This is a schematic drawing from Professor Szentagotay, and very good, very useful for the third semester as well. You can imagine a horizontal cut through the angle of the mouth, and this cut happens to go through the first vertebra behind, through the atlas behind. Not every detail is important for this semester, especially don't bother with the structures indicated by abbreviations. What you already should recognize in this drawing, lateral wall of the oral cavity, the buccinator muscle continues with the superior constrictor muscle. Inside the superior constrictor, inside the pharynx, there are the two arch-like muscles, the palatoglossus and palatopharyngeus muscles, covered by mucous membrane, of course. And here comes, that is the transected ramus of the mandible. The spaces are to be emphasized, lying behind the pharynx, between the pharynx and the vertebral column, that is called quite like retropharyngeal space. The importance of this space is that downward it has no border. It is continuous with the posterior space of the thoracic cage, and because it contains lymph nodes, and the lymph nodes can be inflamed, and this inflammation can go down, therefore there is no limitation, so directly reaches the posterior mediastinum. This is called the posterior mediastinum in the middle of the thorax, and causing mediastinitis, which could be lethal, so it has great importance. Not the same applies to the parapharyngeal, next to the pharynx, lateral to the pharynx, parapharyngeal space. Also it lacks lower wall or lower margin, but if anything, any inflammation spreads down, it only reaches the subcutaneous space of the neck and not causing any severe problem. And I think briefly that was all about this quite complex thing. I wish you luck and wish you a good success in studying. Thank you for listening.